welcome. Hi, I'm Ed Salek, and the show is in honor of, and it is our honor to continually bring you programs that are beneficial to veterans and their families and the general public to be aware of what is being done for veterans, the guys who are out there defending our country all the time. We have a very special show today we want to discuss. It was once said, and I'm stealing the line from one of our guests actually, but that one suicide is too many among veterans groups. And we were going to talk today about what the VA and what the veterans are receiving in the way of benefits and what we can do to help them and their families. Before we get into that, I'd like to point out to that all of the programming that we do is available on YouTube, and it's under my name, Ed Salek, S-A-L-E-K, and you can go onto YouTube and watch the program. If you have veterans that are in California or Colorado or Hawaii, you can tell them, go on YouTube, and they can pick up all of the information that's disseminated in our programs. It's not just available on the television here in the Staten Island, Brooklyn area. So keep that in mind, please. I'd like to welcome Dr. Adam Wolkin, who's been with us before, and we thank you for coming, and we thank you for reaching out for us for this. Kate Mostkoff and Kellie Meiseneacher. Okay, thank you so much for being here. And of course, our co-host, Paul Dietrich, who's been with us for every show for the past 500-600 shows that we've done, and we appreciate it. Paul, you wanted to bring us up to date on some information we've been talking about before we get into the program. And then
yes. I just wanted the veterans out there to know that H.R. 299, which is the federal bill for the Blue Water Navy, it's called the Blue Water Navy Act, is being reintroduced in the legislature. This bill was passed unanimously last year in the legislature. However, it was not even brought for a vote in the Senate. The alleged reason in the Senate was that it was felt it was too expensive. This again covers those Vietnam veterans who served offshore on Navy ships, the ones that served on airfields, particularly in Thailand, and it also covers the veterans who served for the entire period of time that Agent Orange was used on the DMZ in Korea. Also included in there is evidence that Agent Orange also can cause some birth defects, and I believe spina bifida is one of those, and that is also covered in that bill. But it is again being reintroduced in the House. Very important that you call your legislators and ask them to sign on as co-sponsors, so this again gets passed by the House and then gets referred to the Senate. At that time, it'll be time to call your senators and to push them. Again, my feelings are on it that if veterans were exposed to a particular toxin, and Agent Orange is a presumptive toxin, particularly for those that were exposed on shore, that we have to take care of them now that they have the diseases that are related to that later in their lives.
Okay.
Okay, doctor, can you tell us what should people really know about suicide and veterans in particular?
So first, I want to thank you for having us on. It's important that we continue to have a discussion with the community at large regarding what can be done to help prevent suicide among veterans. And as you've introduced, I brought with us two of our staff from the New York Harbor Healthcare System who are experts in suicide prevention coordinator, and case manager who will be best suited to answer your questions. I just want to perhaps take a minute to contextualize this and just make it clear that suicide is a universal problem. Suicide, there are over 1 million suicides a year globally, over 45,000 suicides a year in the United States. Suicide in general in the population has been increasing. There's been a 25% increase since 2000. Over half the states in the country have had over a 30% increase. So this is a problem that everyone faces, and the information that we are sharing today is in some ways applicable, or certain elements of it relevant to the population at large, but we are here in particular because the rate among veterans is disproportionately high. At the last tally, while veterans represented 8% of the population, they represented 18% of suicide. So suicide prevention is the #1 clinical priority for VHA and for VA, and we'll be telling you more about the steps that we are taking to help prevent suicide and mitigate risk. So
I'd like to comment very briefly that we want to thank you because the fact that you reached out for us and said, we want to talk about this. We want the word to get out there on the it shows that the VA is proactive in addressing all problems, and especially this problem. And I want to thank you. And I think the viewing audience should be aware of the fact that you brought it to us and you said, let's talk about this. Let's get the word out there. And that's exactly what we're doing. I apologize for interrupting you.
No. So, but going forward, our experts are Kellie and Kate, and can certainly be very happy to answer your questions.
Thank you.
So one of the things that I think about that is that one of the messages that I think is most important to get across is that 90% of those who die by suicide have a diagnosable mental health condition. And so if we can provide treatment for those, we can prevent a lot of suicides.
Okay. Can you tell us about suicide among the veterans population specifically?
So suicide, as Dr. Wolkin mentioned, veterans all veterans are at increased risk for suicide than the general population. So there are a lot of reasons for that. I think that part of it is that they've been exposed to a lot of trauma, a lot of stress, even those who have not been deployed to combat. About half of those who die by suicide have not been deployed to war zones.
I think there's a perception out there in the civilian world that the majority of those who are attempting suicide are the younger veterans who've been on multiple tours to combat zones and things like that. And I think from my own experience, that's not the case. So,
well, I think that deployment, and certainly nowadays multiple deployments, are a risk factor. But as I said, about half of those who die by suicide have not been deployed at all and not been in combat. And
about age.
So even now, in general, the largest number of veterans who die by suicide are over 50. The fastest, on the other hand, the fastest increase in suicide rates are among the younger veterans, those 18 to 25, as well as among women.
I can tell you from my own experience that having served 35 years, that when you're in the service, you always have a buddy. There's always somebody, and usually it's face-to-face type communication. And I'm not saying that any of those is particularly relevant, but my own feeling is that when you have somebody that's always looking out for you, at least making sure you're okay today, that's a big help to you to prevent this type of depression from.
And certainly that transition period is a very difficult one for the veterans who are leaving the service. One veteran once described that to me as, when I was in the service, I always had a mission. And now that I'm home, I don't have a mission. And so that stress of that transition is very difficult.
And to kind of go along with your point, New York State has one of the lowest rates of suicide, where we lead second. And I think that does have a lot to do with decrease in isolation. Some of the states that have the highest rates are more states who are isolated, maybe don't have veterans who don't have a network, or people who don't have a network of people. So I think that there is,
A correlation there somehow.
yeah.
What is the VA doing? What are they offering to veterans in the way of services? Are there any specific programs? New York Harbor Healthcare, you have special programs that you're employing?
So to Kate's point, with the vast majority of veterans who have or at risk have had suicide attempts or at risk for suicide attempts having underlying mental health conditions, of course, there's the fact that we have a very robust program within mental health for treatment of psychiatric disorders. But again, the important point is to look beyond just that relatively confined area, look across our population at large, and we do that through suicide screening. So we have a robust and comprehensive program for suicide screening. Any veteran coming into the emergency room, any veteran being admitted to the hospital, any veteran coming into mental health, in any of those venues, there is a sequential process for more intensive suicide screening depending on the answers. So having that very comprehensive surveillance is the first step, an important step.
Right.
Then depending what we learn, what we find out, what the concerns are, those who are at greater risk would be increasingly triaged toward receiving appropriate further evaluation and treatment if necessary.
We also have a program called REACH-VET, which targets the top percentage of our VA population of veterans who are at higher risk. So identifying those veterans before they're even suicidal is a newer initiative that's recently started at the
Okay,
VA.
you actually look to identify it.
Yeah, it's an algorithm that looks at risks based on either medical, ER visits, and things like that, and to identify that these veterans may be at risk, and then we reach out to them and ask them if they would like additional services and provide them with additional services if they need it.
This is actually a very innovative process that VA has implemented nationwide called REACH-VET. They've developed through research and studies the algorithm by which to find factors to potentially predict or at least to stratify risk for suicide. Every month, that algorithm is rerun, and it's literally the top 0.1% of being at the highest risk are identified for each medical facility. For us at New York Harbor, that's about 40 veterans a month who are identified as being in that very highest risk stratum. And then we in turn will work with the providers to reach out to those veterans, review their care plan, and look into aspects of ways of enhancing and strengthening care in connection to the VA.
One of the things that I hear quite often from some of the veterans that I deal with is, what about the confidentiality of the treatment? Because they're concerned about information getting back to their civilian jobs, whatever they might be. Can you talk a little bit about that to give some reassurance to them on that?
So you have daily interactions with the veterans. How do you reassure them and bring that issue up with them?
Medical records are confidential, and the only breach of confidentiality really is in the case where the veteran may be at risk of harm to themselves or others. That's the only circumstance in which confidentiality can be violated.
Okay.
It may be that it's a sort of a paradigm shift, whereas when veterans had been active service members, understanding that information would be reported to their CO, and we still are in fact obligated to report information back to the CO. But once someone now becomes a veteran, they are under the umbrella of the same HIPAA laws as the rest of the population. There is no one to whom we are obligated, except in cases of emergency, to report that information to, and it's confidential.
I think that's very important to quite a bit of the veteran population. What are the warning signs that you could give out to the general public, or to a family member, or to someone like who might need to intercede?
So I think the primary warning signs are noticing a change in the person's usual behavior. So the person who is suddenly very withdrawn or isolated, who becomes very active, the person who is talking about death or suicide, Those are some of the main warning signs.
And I'll relate my own experience, and we talked about this a little bit before. When I was a commander, I was talking to one of my soldiers who happened to have a very severe medical issue and was in medical treatment at the time. And I was only talking to that person on the phone. Yet, to me, he was doing exactly that. He was talking about he had no reason to live. And I felt that intercession was needed. And we were in different states. And as soon as I got off the phone with him, I talked to the facility they was in. I said, you need to send somebody there now, because he was in a room by himself. And I said, if the door is locked, they need to break it down, because I really think something bad is going to happen. And they said, well, we don't have anybody here now. I said, no. You need to get somebody here now, because that is the level of concern I have. So they did get somebody, but at the same time, I ended up calling my chaplain, who called the chaplain at the facility, happened to know them, and sort of two paths towards one, and the person had attempted to kill themselves by taking pills and was saved. Now this is, to me, is very difficult, because I wasn't face to face with the person, and I'm still from the generation that relates to people by talking to them. Nowadays, it's much more difficult, I think, when people are texting each other or talking, without electronically. So you really need to take action at that point, because otherwise this person would be dead.
Right. Well, I think your story really illustrates some of the sort of key points, that you were attuned to what this person was saying, and you're not a mental health provider
Nope.
yourself. You just, as an individual, you heard the difference between how this person usually talked and how he was talking now, and you were aware of the major change in his life, that he just had a medical complication. And I think that your instinct to make sure that somebody got there immediately was exactly right. That, one of the things that I like to say is that, if somebody is suicidal in your presence, you don't leave them alone.
Yes.
That it's really important that you stay with them and while you're getting help.
I think another important point is this is something on which we want to err on the side of caution.
Absolutely.
We don't need clear and convincing evidence. It's just any suspicion is something to act on. I would much rather have false alarms than to miss something that actually happened. So if there's any question,
yes, my point was,
up.
okay, if you go to this place and the person is fine, great. But I don't feel he's going to be fine. And that was why I went to the extremes that I did.
You reacted appropriately, which is the right thing to do. What can people do to support a veteran that they suspect may be suicidal? Is it okay to ask them about suicide?
Well, actually, I think that that's one of the most important things to do, is to ask them directly, are you having thoughts about killing yourself? And not to ask it in a kind of a vague way. For instance, some people are inclined to, that's a hard thing to ask another person. Are you thinking about killing yourself? It's much easier to say even something like, are you feeling suicidal? Are you thinking about hurting yourself? When a person is acutely suicidal, those suicidal thoughts they're not hurtful. They're thinking about how they're going to feel better. And so we really encourage people to use direct, open, honest questioning, and really to invite a conversation about that.
I think there's a bit of a myth that somehow asking the question is going to make matters worse or is going to put an idea into somebody's head.
That is
And it's
already
quite
pretty
the
bad.
opposite, right? So that really one of the most fundamental issues is just to get past the fact that no, it's not bad to ask about it, it's critical to ask about it, and you are doing good, not damage, by raising the issue.
And in our experience with asking, are you suicidal, and talking about it with veterans, they actually find relief. A lot of them, when they're done speaking with us, say that they feel relieved that they had somebody to talk to about it.
Well, people are still social, so
Yeah.
talking about things in general tends to at least bring them out so that there's a chance of resolving something other than...
I think it's important to know that people who are having suicidal thoughts are often feeling very ashamed of having those thoughts, of not having been able to solve the problems that led to that. And so being able to talk about it really openly, clearly, can be a great relief. I once had a veteran who, after we'd spent a half an hour talking about it, got up and said, I've never talked to anybody about these feelings before. I feel 10 pounds lighter.
Yep.
It does make a difference. And I was a supervisor with the police department, and we had one of our police officers commit suicide. And the funny thing was, when talking to the other police officers he was working with that particular night, they said, hey, he mentioned anyone's going to go kill himself. And he said, we thought he was joking. And we treated it accordingly.
Right.
And it was sad because we could have helped him, And that would apply virtually across the board to anybody in society, not just veterans, not just a specific job category.
If he had just been joking, it would, like your story, if they'd walked into the room and he was fine, that's fine. He was joking. Some people do joke that way.
Yeah.
But I felt strongly enough in my case to tell them if they have to break the door down, you need to break the door down.
Right.
That's how strongly I felt. How about if you're a veteran and you're having these feelings? What can they do right now, and what should they do?
Well, I think that one of the fastest ways to get connected to care is to call the Veterans Crisis Line. The VA, originally in 2007, the VA, recognizing the increased concern for veteran suicide, opened up a hotline. It started upstate in Canandaigua, New York, in the Finger Lakes. And it was originally called the Suicide Hotline. And as it has expanded, they've renamed it the Veterans Crisis Line. And part of that idea is to have people call before they're in such an acute emergent state.
Do you have any numbers you can give out with regard to the crisis line?
1-800-273-8255. Then to press 1 to speak to the Veterans Crisis Line. Up until, I guess, through about 2000, I think the last number that I have, when people call the crisis line, they call with all kinds of problems. Literally, I've had people who call because they need an appointment, or they need their special shoes that were ordered at the VA.
Right.
I had one veteran call because he wanted a Bible. But a fair number of the people who call are calling because they are in great distress, that they've not been connected to services, at any kind of mental health services. The Veterans Crisis Line, they will speak to the person for as long as they need to. They will stay on the phone while the person has taken an overdose of drugs and is falling asleep, and they will stay on the phone with them until they wake up. They will call what they call a rescue, where they They will call the local police and have the police go to the location. They can find the person, and as of, I think, around 2018, they had done over 100,000 rescues.
It's an impressive number. It's a
10 years,
very impressive number.
where they had sent the police out and stopped a suicide.
I think also it's important to note that there have been changes with regards to services at the VA. Specifically now, there's changes with regards to other than honorable discharges. Can you
Right.
speak a little about that?
Yeah, so recently about 500,000 letters went out to veterans who have what's called a other than honorable discharge, and there have been parameters that have been changed in regards to their access to mental health care. So veterans who have served 100 days in the military and were deployed to a combat zone or have experienced military sexual trauma are now potentially eligible for mental health care for as long as they need it. So they can most certainly, contact the Veteran Crisis Line or go to their local VA and check on their eligibility.
And I believe you were even talking that right now there's a direct link between potentially getting the other than honorable change to honorable through the system. Is that correct?
Right. So if veterans present to eligibility, they can get a change in their discharge from other than honorable to general under honorable, which the eligibility office can help them file for while they come in.
Yes.
And get enrolled in care.
I think the important thing is that the condition of the discharge now shouldn't stop them from at least trying to contact
Right.
if they're in this condition where they're potentially considering suicide.
And in any case, if they call the Veteran Crisis Line and they are not eligible for VA services for whatever reason, they still get connected to somebody at the VA who has resources in the community who that might be able to help them, who also still serve veterans.
The viewers, how would you tell them to proceed if they suspected a veteran or someone in their family is in need of help because of some mental disorder where they fear suicide might be in the realm of possibility for that individual? How would you advise them?
Well, I guess the first thing is really to talk to them about what they're feeling. I think the next thing is to offer to try to help them get connected to care, to go with them to a VA or really any mental health provider.
Doctor, I'm going to ask you if you can revisit this with us in 2 months, 3 months.
Certainly.
Come back and join us again and give us anything specifically that we can give to the public, and especially the veterans public, and to help them make their life secure, better. And I can't tell you how much we appreciate you doing this. Kate, Kellie, thank you so much for being with us today.
Thank you.
Thank you.